I should probably start by saying that I'm a diabetologist by training, but I think we have more and more interaction with gastroenterologists, with Professor Špičák and his department, because I think there might be a good chance to treat diabetes by endoscopy. But this is not the primary topic of my talk. I would like to talk about the effect of bariatric surgery in patients with type 2 diabetes, which I think is still a very hot and interesting topic in my specialization. So I would like to focus on 4 topics in my presentation. I will just briefly show you our complicated type 2 diabetes treatment algorithm. We have many medications now, a couple of new classes, but we still, in quite a significant amount of patients, cannot really treat diabetes properly. And then I will try to speculate a bit about the mechanisms, how bariatric surgery improves diabetes. I will show you some studies comparing pharmacotherapy versus bariatric surgery in patients with diabetes. And I will also try to draw some perspectives of these approaches. So let me start with type 2 diabetes algorithm. This is combined algorithm of American Diabetes Association and the European Association for the Study of Diabetes. I will not bore you with details, but the thing is that the only thing that we all agreed on is that metformin should be the first choice drug, and then we have different combinations. So to make a long story short, it's complicated to treat patients with long-standing diabetes. We frequently have to use insulin, and sometimes in complicated regimens. Therefore, we always search for some simpler solution, and bariatric surgery could be a very simple and efficacious solution for many patients. So how does bariatric surgery improve diabetes? So you would say, obviously, the patient loses body weight, therefore his diabetes is improved. But it's not that simple. Although we've seen this picture in the previous presentation. If you have a patient who has second or third degree obesity and type 2 diabetes, basically the only way how to reduce his body weight sustainably would be bariatric surgery. I think that that's quite clear from the studies. It's also clear that in the long-term run, there is a reduction of mortality, although there is only one good long-term study with patients who underwent bariatric surgery, which is this Swedish obesity subject study. What we also know is that there is an extremely strong effect of bariatric surgery on diabetes. So there is a remission of diabetes in quite high percentage of patients, and there also is a significant decrease in the number of patients with newly diagnosed diabetes. So what's happening with diabetes in bariatric surgery? It's well known that bariatric surgery, and we have different operations, and Professor Fried will talk about them in more detail, but we know that basically any operation could induce remission in some percentage of patients, and all operations basically would achieve some significant improvement in glucose control. Interestingly, this improvement occurs quite early after surgery. There are some mechanisms for that. Part of it is certainly the liquid diet that patients consume after surgery. It's known that some operations are more efficacious than the others. I will get back to that. There is certainly an important role for some hormonal changes in gastrointestinal tract, and we still don't know all of the details of exact mechanisms. So again, it's complicated to talk about surgical operations in front of a surgeon like Professor Fried, but I will just briefly subdivide the operations into restrictive and combined. So basically that's what is available, or these are the most frequently done operations in the Czech Republic. The gastric banding is not very popular anymore, but you can see that basically the principle is just to create a small pouch of the stomach by the gastric band. And it's basically purely restrictive operation, therefore all of the improvements are basically due to decrease in food intake. Gastric plication, again, just the operation that decreases the stomach volume, and it appears that it's also purely restrictive operation. Then we have sleeve gastrectomy, where the gastric fundus is resected, and in this case, again, majority of the effects is through the restriction of gastric volume, so mostly restrictive operation, but this part of stomach produces ghrelin. Ghrelin is a hormone that increases food intake, so there might be also some endocrine and additional component in the effects of sleeve gastrectomy. And then gastric bypass, which I come back to later on. This is the operation that combines some restriction with also some other effects. So gastric bypass is sort of a typical combined operation. So you can see that there is some gastric restriction, but there is also, importantly, some changes in gastrointestinal tract anatomy. So basically what happens is that proximal part of the small intestine is not anymore the part of the digestive tract, meaning that the food doesn't go here anymore. And the exclusion of duodenum from the contact with food is a very important part of the endocrine changes that are typically seen after this operation. So gastric bypass is very efficacious in improving glucose control, and it's not only the restriction of the size of the stomach, but it's also the fact that duodenum is not in the contact with food anymore. And there are a couple of mechanisms, and the very important part of it are increased concentrations of glucagon like peptide 1 and incretin hormone that is, after this operation, quite significantly increased, about 4- to 5-fold, and this is a long-term increase in GLP-1 that has very important consequences, because GLP-1 is a strong stimulator of insulin secretion. It also decreases glucagon secretion, and this combination can lead to significant improvement of glucose control. It also has some other interesting effects. In type 2 diabetes treatment, we use the so-called incretin-based therapies that either increase the concentrations of endogenous GLP-1, or we use injectables that bind to GLP-1 receptor. And there are some trials showing that with GLP-1 receptor agonists, we can even achieve a significant decrease in cardiovascular morbidity and mortality. So this is certainly a very interesting hormone with multiple effects. Gut microbiota, I'm not going to go there, but it has to be mentioned because it appears, and we have some experts on gut microbiota here, so I will really not go any deeper. But it has been shown that there are some differences in gut microbiota of obese diabetic patient, and also that bariatric surgery can significantly improve it and basically make it more similar to gut microbiota of lean, healthy patients. So there is a lot of literature there. It's still difficult to say how much is gut microbiota the cause of the metabolic disturbances and how much it is just a consequence of metabolic disturbances, but it's certainly in fashion nowadays. Then there are some other mechanisms, bile acids. We have Professor Vitek here, so I'm not going to talk about bile acids. I would be afraid of some good questions. But bile acids are certainly very important signaling molecules in addition to their other functions. And it appears that especially gastric bypass, but also other surgeries can significantly increase the concentrations of bile acids. And these increased concentrations probably can also be part of the mechanism along with some other hormones, some new factors, such as fibroblast growth factor 19, and there are some other interesting hepatokines being regulated by bile acids that can contribute. So basically, what is thought the mechanism could be of this combined operation is that once you exclude duodenum from the contact with food, you probably and that's the hypothesis, you probably decrease the production of some factors that impair insulin secretion. Nobody has ever said what factors these could be, but we have a proof that this works, not only by surgery, but also by endoscopy. And I assume that Dr. Benesh will talk about that later in this session, or I have one picture myself if he is not going to do that. Then another important part is that just by bypassing the proximal part of the small intestine, less digested food can actually get into the more distal part of small intestine. And as a consequence, you have increased secretion of these glucagon-like peptide 1 and possibly also other hormones, because this less digested food has different effect on the stimulation of incretin hormone secretion. So, how efficacious is bariatric surgery? It's very efficacious. Just as a reminder, these are current indications and contraindications of bariatric surgery. I think probably sooner or later we will also see some changes in these BMI cutoff and other values, but this is just the basic, just to remind what kind of patients should be admitted for bariatric surgery. So there are, I would say, not too many good side-to-side comparisons between conservative treatment and bariatric surgery. Nevertheless, whatever you look at, you always see that bariatric surgery is more efficacious. So this is the graph, surgical treatment in blue and medical or lifestyle in red. This is change in glycated hemoglobin in patients with diabetes, and you can see clearly more significant effects of bariatric surgery. There is one very good comparison, not very big study, but nicely done, a randomized trial, which is called Stampede study or Stampede trial, 150 patients. Please note that BMI was quite variable. It started with patients who were only overweight, not necessarily obese. They were randomized into intensive conservative pharmacotherapy or bariatric surgery, which was gastric bypass or sleeve gastrectomy. This is the age. Glycated hemoglobin, 78 millimoles per mole, meaning poor glucose control. And the primary aim that was compared was glycated hemoglobin below 43 millimoles per mole. So the most important findings are basically here. So only 5% of patients who received medical therapy alone were able to achieve this goal of glycated hemoglobin below 43, as compared to 29% who underwent gastric bypass and 23% of patients who underwent sleeve gastrectomy. So I think this is a very clear indication that as far as efficacy is concerned, bariatric surgery is more efficacious. Again, I will not bore you with details of side effects, but there was nothing unexpected, I would say. Obviously, some more infectious and surgery-related complications in the patients after the operation, but nothing major, and I would say a very acceptable safety of bariatric surgery, which I think is a well-known thing that these operations are quite safe in majority of patients. So from our diabetologist perspective, it's important what are the predictors of remission of diabetes, because if we can achieve remission of diabetes, we can certainly markedly affect a long-term prognosis of our patients. So it's younger age, shorter duration of diabetes, the patient not treated with insulin yet, better glucose control, and higher percentage of visceral fat. Basically, it means that if we have a patient who has type 2 diabetes and severe obesity, we should think about bariatric surgery as early as possible. And it's not limited only to severe obesity, because the efficacy is good also in patients with lower BMI. So that's why there was a consensus of endocrinologists and surgeons for the position of bariatric surgery in the treatment algorithm for type 2 diabetes. And basically what it says, I'm not going to go into details, but it basically says that all class 3 obese patients with diabetes should, rather sooner than later, undergo bariatric surgery. And basically the same should be true for patients with second degree of obesity, BMI 35 to 40, and poor glycemic control. And also, we should consider this possibility in less obese patients with second and first degree of obesity. I think this comes more from the United States, where they have more patients with severe obesity, but I mean, it's quite clear that even in the Czech Republic, we definitely should indicate more patients for operation, because we should use these efficacious methods more. So, dear Chairman, ladies and gentlemen, let me go to perspectives first and then conclusions. So perspectives I see are endoscopic methods for the treatment of diabetes, because most of these endoscopic methods can be done without general anesthesia. They can be simpler for the patient. And again, so this is, I can just introduce Dr. Beneš before his presentation. We had opportunity to collaborate with Professor Špičák and Dr. Beneš in this trial, looking at the effect of this duodenojejunal sleeve endobarrier. This is impenetrable sleeve that is endoscopically implanted into duodenum, and it basically prevents duodenum mucosa from the contact with food. And as a result, there are quite some significant improvements in glucose control. These were patients with diabetes in our study, and their glycated hemoglobin went down by 20 millimoles per mole. This is a huge improvement. You wouldn't see anything like that with basically any medication. And also the body weight went down by 10 kilograms. Unfortunately, there were some safety issues with endobarrier, so it's not available anymore. But I think it's a very nice proof of concept that something like that could be used in the future for the treatment of diabetes. So my conclusions: bariatric surgery is the most efficacious method of treatment of obesity and type 2 diabetes, and the only method we have that can achieve diabetes remission. We know that it has a good efficacy, but we don't have still enough trials looking specifically and prospectively on the effects on cardiovascular morbidity and mortality, and also the rate of microvascular diabetic complications. I think we should educate ourselves as endocrinologists to really have this possibility of bariatric surgery as an integral part of our treatment algorithm, because we can really help our patients a lot if we appropriately send him to bariatric surgery. And I think one of the very interesting future prospects are endoscopic methods that can mimic some effects of bariatric surgery. There are quite a few of them on the testing stage, I would say, phase 1, phase 2 trials. So I think we should see more of them quite soon. With that, I would like to thank you very much for your attention.